Let's talk about aneurysmal subarachnoid hemorrhage. So these are most commonly caused by a ruptured saccular aneurysm. A caveat is that most aneurysms are actually asymptomatic and do not rupture. There are some modifiable risk factors that include hypertension and cigarette smoking being the most important ones, but also alcohol use and sympathomimetic drugs. These can be either prescribed or recreational drugs such as meth and cocaine. The main clinical feature to recognize is a sudden onset severe headache, also known as a thunderclap headache. Other symptoms that may be present include vomiting, neck stiffness and pain, and focal neurologic deficits depending on the location of the bleed. Now, meningismus specifically, such as a Kernig or Brudzinski test, if it's positive, it does increase the odds of a subarachnoid hemorrhage by about 6 to 7 times. For early evaluation, in the first 6 hours of symptoms, the CT head is the most important test, and it's done always if a bleed is suspected. So it will be nearly 100% sensitive in the first 6 hours, and it will show up as a hyperintense signal, most commonly in the basal cisterns, and it will also have classically a star-shaped pattern, like here. Now, if the CT head is negative, then lumbar puncture is important because it will still remain sensitive for up to 2 weeks. So it will show xanthochromia and a high red blood cell count. If the lumbar puncture is done in the first 2 or 3 hours, it may be a false negative though. So once a subarachnoid hemorrhage is identified, then the next step is to search for the cause, and you'll want to look for an aneurysm with sometimes people start out with a CT angiogram, but eventually will go to a catheter angiogram, and this is both diagnostic and therapeutic, and it will look kind of like an outpouching in the blood vessel. If it's negative, then the angiogram is repeated somewhere in the first 1 to 2 weeks. So for treatment, the ABCs come first, but after that, you'll want to reverse anticoagulation and stop any antiplatelets. The blood pressure does need to be lowered to 160 systolic or a MAP of under 110, and this will help with preventing rebleeding and re-rupture of the aneurysm. Euvolemia should be maintained with fluids. This is because hypovolemia can cause ischemic problems. So the definitive therapy for the aneurysm should also be done with either clipping or coiling, usually recommended within the first 24 hours. Other complications such as vasospasm is screened for with a daily transcranial Doppler, and seizures are treated as well. Depending on the size of the bleed and the neurologic deficit, some people may even start seizure prophylaxis on presentation. Nimodipine is a pretty important medication to start, and it's continued for 21 days. It's a calcium channel blocker that is thought to reduce vasospasm, but it has been shown to improve morbidity and mortality. So complications to look out for include early rebleeding due to re-rupture. This happens most commonly in the first 2 to 12 hours. And you'll see a decline in mental status and a new hemorrhage on CT. The treatment is to secure the aneurysm with clipping or coiling. Delayed cerebral ischemia is also a common complication, and it will show up as hypodense lesions on CT, and these are thought to be presumably due to vasospasm. So the treatment is to first identify the vasospasm, usually with a CT angiogram, and then use vasopressors to induce hypertension to increase the cerebral perfusion pressure. So Cerebral perfusion pressure is basically a function of the mean arterial pressure minus the intracranial pressure. And so in order to increase cerebral perfusion pressure when there's a vasospasm and a limited blood flow, you'll either have to increase the MAP or decrease the ICP. So in this case, we'll increase the mean arterial pressure. If there is elevated ICP, though, you can also try reducing that. Endovascular procedures can also help in treating vasospasm, and these can be balloon angioplasties or sometimes medications. So other complications can include hyponatremia, and that's either due to SIADH or cerebral salt wasting. The treatment is to make sure that the patients will maintain euvolemia as well as giving hypertonic saline. For hydrocephalus, which can be either communicating or non-communicating, the treatment is a ventriculostomy, and this can also be used to monitor the ICPs as well. For prognosis, the degree of bleeding and neurologic deficit usually determines the prognosis, and there are a few different scoring mechanisms such as the Hunt and Hess score or the World Federation of Neurological Surgeons score. Regardless, in general, the early mortality from a subarachnoid hemorrhage hovers around 30%. There are some predictors of poor outcome, with seizure at presentation being one of them. Long-term complications, though, can include epilepsy, neurocognitive dysfunction, and focal neurological deficits. For screening, let's say if someone comes in and is asymptomatic and is wondering if they need to be screened for an aneurysm, generally the go-ahead to screen for aneurysm is when they have 2 first-degree family members that have had aneurysms.